Welcome viewers, today we are going to discuss the inotropic drugs. The inotropic drugs are the positive inotropic agents, enhance the cardiac contractility and thus increase the cardiac output. Although these drugs act by different mechanisms, the inotropic action is the result of an increased cytoplasmic calcium concentration that enhance the contractility of cardiac muscles. Inotropic drugs are divided into the two groups, basically digitalis glycosides and beta-adrenergic agonist. In the digitalis glycosides, the digoxins and the beta-adrenergic agonist are the dobutamine and dopamine. First of all, we'll discuss the digoxin. Digoxin is a digitalis glycosides, also called the cardiac glycosides. These drugs comes from the digitalis plant, also known as foxglove. They are the group of the chemically similar compounds that can increase the contractility of the heart muscles and therefore are used in the treatment of heart failure. The digitalis glycosides have a low therapeutic index with only a small difference between the therapeutic dose and dose that are toxic or over even fatal. The only available agent is the digoxin. As far as the mechanism of action of the digoxin is concerned, there are two mechanism of actions. Number one is the regulation of the cytosolic calcium concentration, and other one is the increased contractility of the cardiac muscle. First of all, we'll discuss the regulation of cytosolic calcium concentration. In this mechanism, the digoxin act by inhibiting the sodium-potassium adenosine triphosphate phosphatase enzymes. Sodium-potassium, in other words, sodium-potassium ATPases. Basically, what happened normally when the sodium-potassium exchangers, the sodium-potassium ATPases are working, and the sodium is coming into the cell and potassium is coming into the cell and sodium is going out from the cells. And this compensatory mechanism, what happened, this sodium calcium exchanger is activated to compensate this outflux of the sodium. They will push the sodium inside the cells. As the sodium is pushing by the sodium calcium exchanger, the calcium is going out from the cell. So the cell become poor in the calcium and rich in the sodium. Here the sodium is going poor in the sodium, and when the sodium is coming in, the cells then again rich in sodium and poor in calcium. What happened when the digoxin if the calcium is poor, calcium is become poor here, then the contractility of the muscles will be decreased. What happened? These are basically the cardiac increase. These drugs are basically to increase the cardiac contractility. What happened when the sodium potassium ATPases is blocked by the digoxin? It will inhibit the digoxin. There will be the no influx of the potassium and no outflux of the sodium. No sodium calcium exchanger will be working. So the inside at this here inside calcium level will be increased and the free calcium level will be increased, which act on this muscles and we contract this actin and myosin. So let's look over here. The concentration of the intracellular sodium increases. Concentration of the sodium, as I said, that the cell become poor in the sodium, the concentration gradient across the membrane decreases. The concentration membrane across it decreases. What happened over here? Increased sodium decreases the driving force of the sodium calcium exchange, so there is a decrease in the extrusion of the calcium, decrease in the extrusion of the sodium into the extracellular spaces, and the free calcium will be enhanced or increased over here, which will cause the cardiac contractility. Another one is the inotropic mechanism of the inotropic drug is the increased contractility of the cardiac muscles. What happened? Look at this diagram. Before going to this, digoxin increase the force of the cardiac contraction, causing the cardiac output to more closely resemble that of the normal heart. Vagal tone is also enhanced, so both heart rate and the myocardial oxygen demand decreases. Digoxin slows conduction velocities through the atrioventricular node, making it useful for the atrial fibrillation. Now, look at this graphical representation. It's here, and along the y-axis there is a cardiac output, and along the x-axis there is a cardiac and ventricular and diastolic pressure. Look at this black curve. A is basically a normal heart. A is the normal operating point in the healthy heart. Normal operating point. Within the limits when the cardiac muscle is stressed. When the cardiac muscle is stretched, what happened? Its force of contraction increases, and hence the cardiac output increases. Force of contraction increases and cardiac output increases to this. However, if the ventricle is overly stretched, the effect of the ventricular contraction is diminishes. Effect of the ventricular contraction is diminishes, and is a normal heart. What happened in the heart failure? The cardiac output decreases. Initially, reduction of the cardiac means, in other words, you can say reduction of the contractility decreases due to the heart failure. Due to the heart failure, symptoms of this low cardiac output, the cardiac output decreases, contractility decreases, cardiac output decreases. The symptom of the cardiac output develop, that is the fatigued. Here the heart become fatigued, means cardiac output decreases, contractility decreases. Here is the decompensated heart failure. It's a decompensated heart failure. What happened? In this decompensated heart failure, the heart is trying to compensate it. How? Ventricular and diastolic pressure increases. Ventricular and diastolic pressure increases from B to C, B point to C. Means if the contractility decreases, heart failure, contractility decreases, cardiac output decreases, the heart is a heart failure. The heart become fatigued or in a failure. What happened? Heart will try itself to compensate the heart failure. What happened? Ventricular and diastolic pressure increases in effort to maintain the adequate cardiac output. The increased ventricular and diastolic pressure, this increased ventricular and diastolic pressure causes the symptoms of the congestion. Here the congestion will be happened. For example, dyspnea will be happened. Means dyspnea will be happened. Here it's a normal response of this normal effort of the heart to this heart failure state. What happened? If heart is not been treated, it will remain untreated. It means cardiac output will regularly decreased, contractility will again decreased, and the heart become in a failure state. So what happened if we apply the drug over here at this point, means digoxin? If we apply the digoxin for the treatment, what will be happen? The cardiac output increase, contractility become increase. Here the contractility become increase, contractility leads to increase the, this contractility increases leads to increase the cardiac output, decrease sympathetic reflexes, and the vascular tone causes the decrease in the ventricular and diastolic pressure. Again look at this, here is the heart is compensated, normally compensated. If it has been treated over here by the digoxin, what will be happen? The cardiac output is increases, contractility increases, decrease sympathetic and the sympathetic reflexes decreases, and ventricular tone cause a decrease in a ventricular and diastolic pressure, that is D2 E point, and diastolic pressure. That is the, if that is the that is very much closer to the, as I previously discussed that it is very you can say I said that digoxin increase the force of cardiac contractility. Digoxin increase the force of cardiac contractility or cardiac contraction, causing the cardiac output to more closely resemble to the, you can say that of the normal heart. It is all about the mechanism of the digoxin. Let's go a little bit detail. Increase the force of cardiac contraction, causing the cardiac output. Improve circulation leads to reduce the sympathetic activity. Which then reduce the peripheral resistance with the reduction in the heart rate. Slows down the conduction velocity. Digoxin, another function of the digoxin is that it slows down the conduction velocity through a atrioventricular node, which accounts for its use in the atrial fibrillation. Moreover, if we go in another little bit detail of the functions of the digoxin, that increase the force of cardiac contraction, causing the cardiac output to more closely resemble, as I already discussed, resemble that of the normal heart. Vagal tone is also enhanced, so both heart rate and the myocardial oxygen demand decreases, as I already discussed in the previous slide of the graphical representation. It's all the details which I discussed here are in the written form over here. Digoxin slows the conduction velocity through the atrioventricular node, making it useful for the atrial fibrillation. Very potent. It's very potent. Digoxin is very potent. Available in the oral and injectable formulations, with a narrow margin of the safety and long half-life of around 36 hours. Mainly eliminated intact by the kidney, requiring dose adjustment based on the creatinine clearance. If there is a renal failure, then creatinine clearance needs a dose adjustment. Adverse effects, according to the cardiac effects, mainly cardiac adverse effects are the arrhythmias, mainly slowing of the atrioventricular conduction associated with the atrial arrhythmias, you can say. Intracellular potassium also decreases, and GAT adverse effects are concerned: anorexia, nausea, vomiting. CNS are adverse effects: the headache, fatigue, confusion, and blurred vision, etc. Dopamine and dobutamine. Our next is the dopamine and the dobutamine. What are these drugs? Dopamine and dobutamine basically we already discussed. These are basically the inotropic drugs, and these are the beta adrenergic agonist. Beta adrenergic agonists are basically the drugs which such as the dobutamine and the dopamine improve the cardiac performance by causing the positive inotropic effect and vasodilation. Beta adrenergic agonist ultimately leads to increase the entry of calcium ions into the myocardial cells and enhance the contraction. Both of these drugs must be given intravenously infusions and are primarily used in the short-term treatment of acute heart failure in hospitalized settings. This dopamine in this I would like to tell you the dopamine is a strong beta 1 adrenergic and alpha 1 adrenergic drug, and it is a dose related effect. Its effects are the dose related. Dobutamine has a selective beta 1 agonist and has no effect on the dopamine receptors. As I previously discussed, dopamine is a dose related effects. At the low dose, they stimulate mainly the dopaminergic receptors, producing the renal and mesenteric vasodilation. Basically, the effect are the vasodilation. High doses stimulate both beta 1 adrenergic and dopaminergic receptors, producing the cardiac stimulation and the renal vasodilation. Are metabolized by the liver, kidney, and by the enzymes monoamine oxidase and the catecholamine O methyltransferase, that is a COMT enzymes. They are mostly useful in the patient with the failure complicated by the severe hypotension, must be given intravenously, and is primarily used in the treatment of the acute heart failure in the hospitalized patients. It is the mechanism of action of the beta adrenergic agonist drugs. It is a dobutamine and butamine. They act here and increase at beta adrenergic agonist drugs. Basically, these are the beta adrenergic agonist drugs. They act over here at this beta adrenergic receptors, and then it will increase the cyclic. It will activate or produce the cyclic AMP through the ATP. If the cyclic AMP level is increased, what happened? Cyclic AMP activates the protein kinase. This protein kinase this protein kinase causes the phosphorylation of the calcium channels. These calcium channels open and calcium coming in through the voltage sensitive slow calcium channels, and the phosphorylation of the calcium channel increase the calcium flow and causing the increased force of contraction of the heart muscles. It is the mechanism of action of dobutamine and the dopamine. Very simple, phosphodiesterase is another compound, that is the enamiron and the milarinon. These are the drugs that increase the intracellular concentration of the cyclic AMP. This results in increased intracellular calcium and therefore cardiac contractility. This drug is indicated for the short-term IV use in the severe and the refractory congestive heart failure. They cause balanced atrial and the venous dilation with the consequent fall in the systemic and the pulmonary vascular resistance and left and right heart filling pressure. Thrombocytopenia and arrhythmias are the major adverse effect of the phosphodiesterase inhibitors. Basically, phosphodiesterase, what are they doing? Phosphodiesterase inhibitor prevent the hydrolysis of the cyclic AMP and thus prolong the action of protein kinase. Prolong the action of the protein kinase. It is all about the inotropic drugs. Thanks for watching and stay tuned with the Sunny Clicks by Shfik Sunny.